The Spinoff Podcast Network.
K-pop to me means more than just listening to music. It's learning to be myself.
The Spinoff's new documentary, K-Pollies, follows 3 Pacific youth obsessed with K-pop. In a one-off documentary, see what they've found in Korean pop culture and how they bridge it with their own.
When you start dressing, looking different, everyone side-eyes you. But in K-pop, they're just like, no, like celebrate yourself.
Watch K-Pollies today at thespinoff.co.nz/videos. Made with the support of New Zealand On Air. You're listening to Business is Boring, a podcast that reckons it's anything but. Business is Boring is brought to you by SparkLab, offering inspiration and practical advice to help businesses find their edge. To hear more about SparkLab, including details about the latest events, workshops, and business tools, visit sparklab.co.nz. And now, here's your host, Simon Pound.
You're listening to Business is Boring, a podcast that reckons it's anything but. Business is Boring is made by the Spinoff with help from Callaghan Innovation, New Zealand's innovation agency. Here's your host, Simon Pound.
People aren't standard, yet best medical practice often has to be. Treatments for conditions and prescriptions for ailments are most often based off studies where, by design, they found the average need and effective dosage. But we know people are not average. There are distinct ways different bodies metabolize, for example, which means that for some, the average dose will never work because they metabolize it too fast, and others it won't work for as they do so too slowly. Which is part of why there is now an emerging field of pharmacology that uses gene sequencing to understand how an individual's body works and then equip them and their doctors with that information and understanding to help ensure the correct prescriptions are given. It's just one of the exciting ways to put power in patients' hands that have been pioneered out of the Pinnacle group of not-for-profit companies. They're a huge force in the Midlands. Its members manage the healthcare of nearly 500,000 people enrolled with over 80 practices in Gisborne, Taranaki, Taupo, Turangi, Thames Coromandel and the Waikato. The CEO that has driven their growth, first for the whole family of companies and very recently for their ventures arm, is John Macaskill-Smith, who is here today to talk about using business to change health, introducing the pharmacogenomics, and how you can find out more about how your body is likely to react to drugs. G'day, thanks for joining us, John.
Hey, no worries. It's good to be here.
Hey, so tell me, how did you come to get involved in this role?
Wow. It's a long story, but, I'd been working in the health sector and getting more and more frustrated with how the system wasn't really working that well. So I kind of jumped the fence from provider land into a funding role and ended up working in a number of government agencies and really trying to be quite pragmatic, cut through a lot of the bureaucracy and try and make things kind of happen on the ground. And it was 2000, I think Labor came in and shut down the National Health Funding Authority and moved to district health boards. And it was at that time that I didn't really want to go into a district health board, which was quite a hospital kind of focused construct. And I ended up being offered a role in a large primary care network. So I stepped into that, and what I've loved about it is it's an organisation that has to deal with we've got 100 small business owners that we need to work with. So those are the GPs, down the road who run the little clinic. But we've also got to deal with the district health boards, the hospitals, the ministry. There's a couple of $100 million worth of taxpayers' funding that goes kind of through us. And we're constantly looking at how we can innovate to keep 500,000 people healthy, but also keep them well. And I think the health system in New Zealand is very focused on fixing people, but it's not that good at actually looking at how do we keep people well and stop them actually getting sick.
Yeah, because the big promise of the move to things like primary health organisations and community-based kind of care was that it could be proactive rather than a reactive system. But it's taken a lot of tools and a lot of learning to get there, hasn't it? Like, what kind of things have you done with technology to help enable all of these small GP practices through those regions to be able to serve and kind of predict what their patients are going to need?
Yeah, well, look, one of the things, and in health, there's so much data that we kind of have, and the way that we've organised the health system has really been around services. So, you might have a sore knee, so you've got a service that focuses on that. You might have diabetes, so you've got another service that focuses on that. And the problem is most of those services have just contained and siloed off those pieces of information. So as people, we become kind of recorded by the bits of our body or the things, the ailments that we've kind of got, rather than as a total kind of person. Now, the opportunity with primary care is that general practice is often the single place in the health sector where the whole thing's taken into account. So often, people are coming in, they've got family issues, they've got social issues, they've got housing issues, and they've got clinical issues. And all of that information is, put in a single kind of place. And one of the things that we've worked really hard to do is to say, well, how can we take that information that's often recorded in a kind of server in a hot water cupboard in the little local bungalow of your GP and make it available for the rest of the system to be able to interact with, but also for patients to be able to have in their hands to help them self-manage. Because, look, let's face it, we manage our own care 99% of the time. Health services just intervene now and again. So we've spent a lot of time shifting people's health records into a secure cloud environment, building open APIs, and making that information available for others to be able to access.
And that must be something that's becoming more important as well, as for many people, especially in the bigger urban environments, they don't have a GP anymore, a family GP that's the same person that knew them and their mum and their dad and looks after them through their life. Like, people go to the big the big corporate-owned organisations and get whatever doctor's on.
That's right. And look, that's a global change that's kind of happening to the way that primary and community care is kind of organised. There's a whole generation now that's coming through that, as you've just pointed out, don't tend to have a family GP. So as they need care, they'll just purchase that care from the most convenient kind of space. And we've seen in places like London, for example, Babylon, which is an online kind of service. And it is the younger generation that are using that. So dial up a doc, pay a fixed amount, do it over your smartphone, and have your, if you need a script or medication, have it delivered to the local pharmacy. But look, what does happen is, as you age or if you develop long-term chronic kind of conditions, the numbers are really clear. That's when people want an ongoing relationship. So, if you're coming back in to talk about a condition that's affecting your lifestyle, you want to come back and not have to tell the whole story again and again. You want to be able to come back and you want to have someone who knows you, knows your kind of social setting, your family setting, those other kind of things, have a massive impact on how your health is going. And that's where we see the switch occurring. So just as we do in other parts of our lives, it's convenient to do some things online, and it's quicker and faster to do things that way. Other times we want to go in and we want to be able to fondle something or push the buttons or test it before we kind of buy it. I think health's exactly the same.
And in terms of what you've been providing through the Pinnacle Group to those GPs and to those health practices, you've been enabling a lot of them to bring in some of those virtual elements of care, haven't you? The phone calls, the Skypes, the kind of the digital rather than the in-person checkups.
Yeah, well, look, for us, we cover that middle part of the North Island, and, we've got more people living in small communities of 10,000 people or less. And, of course, what we've seen in that kind of out of the larger urban areas, we've seen this real withdrawal of face-to-face kind of services. We've also seen a real change in our workforce. So, we've got an ageing workforce. Our GPs, their average age is in the late 50s, early 60s. So it's harder for people in those rural communities to be able to even access care. So we've had to have stepped in and started to look at what those virtual kind of services could be and how they could work. But, if you're a busy farmer and you're in the middle of calving, are you really going to stop and go in with a minor ailment? But if you can drop an email, snap a photo, flick that into your doctor and say, do I need to worry about that? That's great. for the individual. And it actually works really well for the doc as well, because a lot of those things don't need someone in the clinic clogging up a consult.
Yeah, and it's really hard, isn't it? Especially in those areas where the population is aging and it's hard to attract doctors. How do services like the things that you've built to make it a bit easier, how does that help people kind of keep managing it as well?
Well, there's a couple of things on that front. It's helping people stay at home is really important, and sometimes having access to your own health record so that you can, dial up the information around your medications and query it against other things online has become really important. We're currently working on some stuff where we're using voice technology to enable people to interact with their health record using like the Alexas or the Google Homes to check their medication, order repeat scripts, or even make appointments. And those kind of things are reducing some of the technology barriers for people who can't navigate or aren't comfortable navigating their way around a sort of complex health electronic system. They can just talk to it and say, "Hey Alexa, when am I next due to take a medication and what is it?"
Yeah, and do they then also, does Alexa say, "Take it now," and then I'll tell you you've done it so you know you've done it that day as well?
Well, absolutely. And sometimes it's that prompting. If you've got ongoing lifestyle-based diseases, diabetes is a good one. Sometimes you do need that prompting around diet and other those things and those reminders. And particularly for elderly people who are starting to get a little bit forgetful about those kind of things, having those prompts, is proving to be really useful.
And as part of that mix, so this is stuff that you've over the last 15 kind of years in that space brought in a lot of those things in the cloud, giving people access to their medical records, which, I didn't know that was so available, but you've got 500,000 people who've got the option to log in and see their medical records in those areas. Is that right?
Yeah, that's absolutely correct. And look, the really interesting thing in here, the barrier to it's not the patients. The barrier to it is typically the providers. So you've got, doctors and nurses or service providers who are anxious about opening up their records. And I say their records because that's often how they view them, as opposed to the view that we've really taken is that actually they're your records and someone's provided some support to you in managing your own care. So they should be available to everyone and you should be able to query them. And, as we've opened them up, there's been concerns from a lot of providers that, people are just going to bombard them with questions. People are going to use that information to kind of Google their own health and take them off. That just hasn't happened. I can count on, a couple of hands the issues that have arisen. And most of those issues that have arisen have been people saying, that didn't happen to me, but it's in my record. I think you've got that wrong, or you've missed this. So I think that's a great process to go through. And the providers that have adopted it, once they get over that initial hump of fear, are actually finding it's a great tool to have in the box to help them work with patients.
Yeah, Dr. Google has been a big worry for the industry in lots of ways. But I think, and it seems very much to be the kind of model you take, that it's always going to be the role of a doctor or a medical professional to be able to help contextualize all of the information that people have. And so the stuff they've Googled online where everything seems to be fatal, doesn't matter what your symptoms are, to be able to put that in context for people. And so I suppose that's part also of the having more ways that people can contact and not just that wait until you're in a serious enough predicament to come into a practice.
That's right. So you can be much more proactive. And I think the other thing we're seeing is a lot more people are using apps to help keep well. So we've got the whole fitness kind of craze. We've got the dieting kind of I won't say it's a craze, but the people are using those kind of apps to help them to keep on track, tracking their calorie intake, tracking the amount of fitness they're doing to kind of contribute to that. And so we've got the wearables that are kind of coming in. We've got those apps that are kind of coming in, and people are subscribing to those things and actually starting to spend big money if you add that up. Often more money in that end of the thing than they are in actually engaging with the health sector. So the health sector needs to work out how it can partner with that part of the, the environment to bring, that specialised knowledge and intervention in so that it's more useful rather than it being a separate thing that you only access when you're really sick.
And that brings us quite nicely to what you've been something that you're pioneering here, the latest in the long line of things with the pharmacogenomics. Hey, so that's really putting the power in the patient hand, isn't it? If you're helping to enable people to sequence part of their DNA to find out how their bodies work. Tell us about what the idea is there.
Well, look, the idea is that we're all unique. None of us are the same, and we're a combination of our parents, at a genetic kind of level, and then the rest of it's our social kind of setting, and all of those things: what we eat, how much we exercise, whether we smoke, whether we do other things, they all contribute to how we kind of come together. But traditionally, the health sector's used, as you mentioned in the intro, a pretty blunt approach to testing stuff. So we've had clinical trials, and a clinical trial usually results in a bell curve of response. And that bell curve is really about the people that have been involved in that trial and how people have responded to that, and the assumption that everyone's kind of fits into that average bell curve. And so the dosage, starting dosage for medications, or even the medications we use to treat particular disease or issues, is based on those traditional kind of approaches. What that misses out is the fact that often we're not all in that bell curve. So if there's only been 3,000 or 4,000 people involved and they all live in Europe, they're very different from 2,000 or 3,000 people who live here in New Zealand. So pharmacogenomics gives us the opportunity to actually use individualised insights into how we individually metabolise different kind of compounds, and to prescribe more precisely. So it's really about the introduction of precision medicine. So how can we move away from the generic and start to move to the precise?
And that idea about not being represented there, is that different communities have different general patterns of how their bodies might metabolize or might interact with certain kind of drugs?
Absolutely, it means that. And look, the easiest way to kind of get your head around that is to think about caffeine. So, we all know, we've all got friends who, if they sniff caffeine, they are just awake for a week. And we have other people that just seem to have a backpack. They just suck it non-stop all day, and it doesn't seem to have any impact. They have it as they go to bed. That's a really good day-to-day example of how different bodies metabolize different compounds differently. So, if people are metabolizing it really quickly or really slowly, it has a different kind of impact. Yeah.
And how about a place like New Zealand with a large Pacific Island population, Māori population? Would people of those backgrounds be appearing in the places where these drugs were originally trialled?
In short, no. And what we do know from the evidence base that we've got at the moment is that a lot of those different ethnic groups that you're mentioning do metabolise different types of medications quite differently. So, for example, a very, very common medications used to manage blood pressure and diabetes have very little impact for some of those ethnic groups. And so what we end up happening is that doctors are using the clinical information they have, the prescribing information, and often they're increasing dosages of medications to try and get the response that they are expecting to get from that kind of intervention, without the understanding that actually it doesn't matter how high you make that dose, that individual's a non-responder to that particular medication. So particularly for Māori and Pacific, that's something that we need to understand better. Now, the evidence base that's there around pharmacogenomics is very, very strong, but it's lacking some of the data and evidence from some particular ethnic kind of groups, in particular Māori and Pacific. So part of what we're doing here is working with Otago and Auckland University, health and some other key national and regional iwi groups to try and bring in a better understanding of, in particular, the Māori genome. So this kind of program is, going to significantly contribute to that information base.
And so how does that actually work? So you've partnered up with an international agency that can take a sample and give people the information. walk us through that process.
Yeah, well, so here's the puzzle. If you're a dairy cow in New Zealand, you can have your whole genome processed real quick for almost no cost. So the national dairy herds managed using genomics. So the whole breeding program, the thing's fascinating. I got stuck in a tent on a school camp between two of the LIC executives, and I can tell you all about Mary Bell and all her offspring.
Well, I mean, and anyone who's seen A2 Milk, that's the very consumer-facing end of that research.
That's right. So look, the process is complex in New Zealand because we have no labs in New Zealand that are actually certified to process commercially human DNA. So at the moment, any of that work is either being done in small uncertified university labs for research things, or we have to go offshore. And this is where it gets really interesting because, online there's over 600 direct-to-consumer kind of options in which you could dial into, have a kit and either send blood or a saliva or a cheek swab back to one of these offshore companies, and in return they'll send you a series of reports. And there's a spectrum of those reports. So some of them are at the kind of wooey end. They're kind of pretty soft evidence, but they kind of appear glamorous. At the other end, they're much more scientific, so that, particularly the pharmacogenomic kind of end. There's also been some of the high-profile stuff where people have used genetic screening in a predictive way to look at, the likelihood of developing things like breast cancer and others. There's been actors that have, made pretty big choices about managing that risk. What's common with most of those online companies is that you give away your personal DNA. So you send it off, you get a report back that gives you whatever you thought you were buying, but what then happens to your DNA is kind of pretty vague. And many countries actually don't have any legislation or protection around that. But look, back to your question, what happens? How do you do it? So look, we've gone for a cheek swab. So essentially your GP, or you could choose to do it yourself directly online, can order up a kit. The kit is then you scrape the inside of your cheek, shove that in a secure little capsule and post that off. It goes to a laboratory in Melbourne. And that is processed. It takes about between 5 and 10 days, depending on post and, other exciting things that can happen in between. And then a report is produced. Now that report, if it's a medication or the PGX-based report, is sent back to your doctor or to one of our doctors who will then contact you and have a virtual consultation with you and walk you through the results.
Right. So that's different than the well-known ones are probably the 23andMe or the Ancestry ones that people have done, where you get a cool PDF back, but you don't actually get a medical professional to help contextualize it for you if you have. Yeah, they specifically dropped a lot of what you're trying to do around how bodies metabolize for drugs.
Yeah, no, that's true. And I think, a lot of those companies have gone on to then sell your DNA to pharmaceutical companies, insurance providers and other kind of things. And, in the States, we've seen some legislation come through that's kind of halted some of that sort of uncontrolled use of DNA. So I guess what we've tried to do in New Zealand is twofold. One, as consumers, it's a global market that we operate in. So the internet provides us with direct access to any product anywhere. So that's just a reality that we need to deal with. Secondly, we've got, our GP or our clinical community in New Zealand's not well trained in the use of genetics. It's new and emerging. You go to the med schools, it's a very tiny part of the training that a medic kind of goes through. We sit down with the groups of our GPs. They always split into two. Half of the room just looks bored, their eyes roll back, and it's like, this is a Star Trek conversation. It's not happening in my lifetime. The other half tend to look a little uncomfortable and sweaty, and then, acknowledge in the end that they know that it's there, but they know that they don't know enough. So we're trying to prepare our clinical workforce so that when patients do come in with the documents and the 23andMe kind of things, that one, they know what it is, two, they know how to read and understand that, but also three, they've got kind of a trusted, credible, signed-off alternative to that. And so that's what we're trying to do. We're trying to put on the table a kind of understood version of that. So, things that we've worked really hard on is it's your genetic information, it's your DNA. So it should be stored in your health record, not in some offshore mass database that's used for other purposes. if you consent to, contributing your DNA to some research, you should know what that research is and you should get feedback on that. So certainly that's the relationship that we've developed with the med schools and others to enable that to occur, but it's a consented kind of process. We're trying to train our workforce so that they know how to respond to the information and how to use it. We're trying to assure New Zealanders that actually if you use a trusted process like this, your information will be stuck back in your health record. It's then protected by the legislation that sits around health information in New Zealand. And thirdly, if it's going to be used for research, you need to be involved in that kind of conversation.
Yeah, those questions around data and consent are really interesting. I listened to an interesting talk with the CEO at 23andMe, and all of these companies have been kind of lumped in together with the cases, which wasn't through 23andMe, but of a killer being caught because of maternal DNA being tracked through and then identifying a person from a DNA database. But she made the point that was really interesting, that a lot of people who do have, especially kind of genetic-based or other forms of very serious illnesses, they want to be part of research. They want their DNA to go into these things. So there are some people who the privacy is very important, but of course some people where helping to forge new research is of real interest to them.
Absolutely. But it should be a choice that you've got. It shouldn't be something that an organisation is kind of doing in the background, often without your full understanding about it. And I think the challenge that we can see is that often New Zealand, is out of a lot of those big research things. I mean, you raised it before. Māori and Pacific genetic information. There's not enough that's understood about that. There's some real cultural concerns around how that information is used. We've seen previously in New Zealand genetic material that's been gathered through crime scenes, gathered together, and I don't know whether you remember a few years ago there was a whole thing about the Māori warrior gene that kind of blew up out of some pretty dodgy research really. Genetic material that was gathered from singular kind of places, no consent, and then all kinds of strange claims that were made about that. So we're wanting to make sure that New Zealanders can feel confident if they're going to use a service like this. But look, the other thing that we're trying to do is the test that we are looking at making available is an enduring test. So it pulls out and identifies a number of your genes. And then as the evidence base will continue to grow around how different medications respond to your particular gene kind of combination, that information can be used again and again and again. So those biomarkers, we're looking at embedding that in your health record so that now and into the future, any clinician who's using your health record and writing a script, those biomarkers will prompt that script writing. So even if the clinician themselves isn't completely aware of it, one of the things we're doing is building an electronic clinical decision support tool that will prompt them and say, hey, Simon's got this particular marker, he's an ultra-rapid metabolizer for this, so the starting dose of warfarin needs to be adjusted to this to avoid an adverse kind of reaction occurring. So we think that's pretty important, and it's pretty amazing. The cost of the test is pretty small. It's enduring, so it's life lasting. It lasts your whole life. And as the evidence grows, it's just going to become more and more kind of powerful.
It's interesting, John, you mentioned their cost as well, because that's become one of the great kind of inequalities of modern medicine, where so much of the really interesting and exciting stuff is not available to the people that need it the most. People who are battling serious health issues often are having financial issues at the same time as a result, or they could be in systems where insurance is required to access this stuff. What are you able to do, and what kind of work are you doing through our great kind of socialized system of medicine to mean that this isn't a problem that you're facing?
Yeah, look, that's a fantastic question, because I think some of the criticism that we've had thrown at us is this is another kind of service for the wealthy, and I think the cost of these kinds of tests in the past have been really kind of prohibitive. The cost of the test now is getting lower and lower, and depending on how many people are going to go through a kind of program, I mean, it's less than $100 now, whereas years ago it was, thousands and tens of thousands of dollars. We're really lucky in New Zealand that we've got a, largely taxpayer-funded health system. The problem is with it, as I said before, 90% of the funds really go into acute care after you're sick and after the fact. Somehow we need to get the politicians and the bureaucrats to understand that we need a bigger investment kind of up front. Now, we already have screening programs that test for particular things when children are born and other things. The cost of undertaking something like a pharmacogenomic test and sticking those biomarkers in an individual's health record could be as low as $20. I don't think that's a prohibitive cost for the sector. Think about it. If you think about the savings in reduction in adverse reactions, savings in, misprescribing. So, as people are prescribing, doctors are fumbling around trying to get the dosages right. Prescription of medications that, people are non-responders to. All of those kind of things. You add up the cost of that compared to that kind of cost as an intervention. So, look, one of the things that we're doing, we're lucky enough that we're working with Callaghan Innovation. So they've recognised that there's an opportunity here for New Zealand Inc., but also kind of globally, because this is the first time that this is happening anywhere in the world, where we're taking a pharmacogenomic panel, we're taking those biomarkers and we're sticking it in someone's health record in primary care. So you see places like the Mayo Clinic in the States, as you admitted, they run the same panel that we're running, but that's to do with people in that hospital environment. No one else is doing it in primary care. And so Callaghan have recognised there's an opportunity to really test the impact of that, but also to look at the impact and the commercials around having the electronic clinical decision tool there to support prescribers as they write the scripts.
Yeah, tell me how that works. So would that literally be kind of a list of all the things that are commonly prescribed in New Zealand and how they react compared to the way that these bodies metabolise, as you found out through this test, and then you just bung in the markers, bung in the thing you want to prescribe, and then get told use more, less, or maybe try this other one.
You make it sound so simple, but yes.
Well, that sounds pretty cool, and like it has some pretty big international applicability.
Well, it does. And look, there's international guidelines and research that being publicised. The FDA in the States require that all medication now has biomarker information within its prescribing information. In New Zealand, that's not purchased currently through the government, so medications are not required if there is biomarker information for that to be available. So things like the New Zealand formulary, which is where most prescribing medics will go to understand New Zealand meds and how they operate and how they're funded, won't have that information. So at the moment we're having to consume that international information. But even this project has triggered a conversation with the New Zealand formulary around actually maybe we do need to publish those kind of biomarkers.
And in terms of the way that you're set up to run as well, because some of the big questions around this, truly exciting and, revolutionary field of medicine, they often come back to kind of whether people will be excluded, if they are tested at birth and it turns out that there's likely to be long-term health issues, whether they'll be excluded from insurance or whether they'll be treated as having less potential in life. There's those big kind of questions around genes, but there's also such an ability to cause so much good from it. How are we going with keeping up with legislation and the like? Because I think America's a little bit further ahead in not being able to discriminate on the basis of the findings of these surveys.
Yeah, so look, I think there's two issues in what you asked. Firstly, yes, you're right. With the bigger whole genome and screening for potential disease development, there's a whole lot of consequences. In New Zealand, we haven't had that social debate. There's not the rules in place. So the test that we're running is a very small subset. So we're pulling, 9 kind of genes to look at how you metabolize drugs. We're not pulling the broader set because we just don't think the rule set's in place for that to be useful. And in some cases it could actually be discriminatory. So we're not going there. But it will have to happen. So hopefully this will trigger some of those discussions and debates to take place.
How interesting. So you're being very focused on just things that have a direct use for patients rather than things that could end up, as you say, because it's an enduring test, could end up counting against them.
Well, that's right. And I mean, we're just looking at how you metabolize different, compounds, and we're embedding that information in your health record. It's a real practical response. General practice and primary care, we're not at the big research end. Yes, we'll partake in that kind of stuff, but we're the ones that are on the ground working with patients and family every day. So we need quick, useful kind of tools and information that we can just apply. So that's what we're trying to do. We're trying to mainstream the massively positive impact of precise medication information to make sure that we can prescribe the right things quicker, get better health outcomes quicker at lower cost, and avoid adverse reactions.
In terms of your model at Pinnacle, which is a really interesting one because it's not for profit, but it does have profit-making engines to then fund more of the other things you do. How cool is it to be able to be pioneering research like this? And if it does take off and become something that is adopted across the world, what would that then enable you to be able to do more of?
Well, more of this exciting researchy kind of stuff. We started off talking about models of care and using technology and all those kind of things. Look, unfortunately, as good as the New Zealand health system is, it's stuck in a sickness model, and it's going broke trying to maintain that. You only have to open one of the mainstream media things to see just how big a deficit the district health boards are carrying. The leadership that sits within the New Zealand health sector is very focused on running hospitals. It's not focused on really understanding how to intervene. You see people like John Tamahiri and others with the whānau ora trying to get that more holistic kind of integrated kind of approach. So for Pinnacle, these kinds of, getting these kind of things right will help us to be able to investigate and invest in more kind of different kind of interventions to help patients have more control of their health and their lives.
What advice do you give to entrepreneurs or people wanting to shake things up? Because I imagine, 15 odd years ago when you jumped into helping run kind of an agency that was bringing together GPs in kind of provincial areas of New Zealand, people wouldn't have looked at it and gone, now there's a place where the biggest innovation in primary healthcare and genetic kind of sequencing and the like is going to come from. So you've driven a huge amount of innovation. How are you able to foster a culture of innovation wherever and whatever work you're doing?
Look, I think there's been a number of things that have been really great and have kept me going. I think actually regional New Zealand's got some secrets that, what's happening in terms of changes in society are often happening quicker in some of the regional kind of areas. The kind of urban retreat, so the withdrawal of services have meant that some of the innovations that we've brought on, the virtual stuff that we talked about at the first, we had to do it because we had no alternative. Our workforce was disappearing in a way that it's not disappearing in the urban kind of setting. So often what you see with, medical provision in urban areas, it's very traditional because there's nothing really to challenge it to change. So operating in the Midland regional kind of area, we've seen withdrawal of workforce, we've seen withdrawal of services. That's been a great driver. But we've also seen people tend to stay in those communities for longer. They're not as transient. So there's some real lifelong relationships that have kind of been there. And the organisation itself is kind of it survived every three-letter acronym that a government could throw at a health sector. So RHAs, HFAs, DHBs, PHOs, IPAs, you name it. We've ridden it out. We just roll the flag up and down depending on what's required. So the organisation has a long-term vision about sustaining high-quality community-based care. So for me, I would say you've got to do some time in the agencies. You need to understand the ministries and, the bureaucracy. But if you really want to drive that change, you need to get outside of those systems because those systems are very constrained and very focused on containment, and find people that you can partner with. The thing that we've found most recently in the ventures part is that we're starting to actually partner up with very, very untraditional partners. We're having a really interesting conversation with the likes of the Warehouse Group about how retail and health could come together in a more, entangled or converged kind of way. Because as consumers, that's where a lot of the action happens rather than siloed kind of sectors. The health sector's not having this conversation. It just talks to itself about how to build a bigger hospital.
How fascinating. And having driven a lot of innovation and pioneered a lot of cool things here, and being on the cusp of some really exciting stuff with gene work. How do you define success? Like, what would be kind of the best outcome in 10 years' time for Pinnacle Ventures?
Oh, well, look, for Pinnacle Ventures, I think that it's we've continued to grow a vibrant health system that sits out of the hospital. So primary and community care is working. And people can access the care that they want, virtually online in different kind of settings, and it's sustainable. Because what we see at the moment is traditional general practice, traditional health service provision isn't sustainable. It's got to change. So a big outcome would be that sustainability. Obviously, health outcome needs to get better, so we're adopting and using the technologies that are kind of available there. And look, at a personal level, the last 15 years I've got out of bed every morning going, right, I'm excited about it. So, I'd like to think I've still got that kind of excitement in getting out of bed. That to me, life is about to be there. It's there to be enjoyed. And so, it's been a real privilege to have a career or a job or a place that I really enjoy, it really engages. And, I think I'm making a bit of a difference.
Wonderful. Well, thank you for coming and sharing the story today, John Macaskill-Smith, who's the CEO of Pinnacle Ventures, who, if you're listening and you're interested, you can find online. Thanks so much.
No worries. Thank you.
Hey, and thank you so much, Tina Tiller, for producing, and thank you very much for listening. If you have enjoyed today, please do jump on iTunes and like and subscribe, as it does help. Thanks so much. Bye.
You've been listening to Business is Boring, presented by Simon Pound. And brought to you by the Spinoff and Callaghan Innovation.
From the Spinoff Podcast Network, that was Business is Boring, brought to you by SparkLab. Make sure you're following Business is Boring wherever you get your podcasts. And for more information on SparkLab, visit sparklab.co.nz. Ready to rediscover the joys of cycling? With over 300 kilometres of cycle paths across Tāmaki Makaurau, jumping on your bike and going for a ride is such a fun way to discover the city from a different perspective. Cycling is getting more and more popular across Auckland, so now's a great time to join the hype and give cycling a go. Head to at.govt/cycling to find your nearest cycleway today. The Spinoff Podcast Network.